Thanks, Simone. Hi everyone, my name is Claire Beecher and I was one of the postdoctoral researchers on the COSUTI study, which was conducted by the Health Research Board Trials Methodology Research Network. So today I'm going to talk to you a little about each of the points on screen. We're going to start with what the COSUTI study was, then move on to the methods that we used. So we had three main stages of the study, so I'll talk a little bit about each of those. Then I'll present our results and there will be some time at the end for some questions if any of you have those. So very simply, the objective of the COSUTI study was to develop a core outcome set for interventions to treat uncomplicated urinary tract infections in adults. We focused specifically on uncomplicated urinary tract infections, or UTI, which typically affect otherwise healthy individuals without known structural or functional abnormalities of the urinary tract. Like I said, COSUTI was conducted by the HRB TMRN, and that was done with funding from the Health Research Board Ireland through the Health Research Board Primary Care Clinical Trials Network. The definition of what a core outcome set, or COS, is displayed on screen, and I've taken this directly from the COMET initiative website. And COMET define COS as an agreed standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. Then in terms of why there's a need for a COS in this particular area, UTIs are among the most common bacterial infections in the outpatient setting. Empirical antimicrobial therapy is often used to treat uncomplicated UTIs, and that then has led to them being a significant cause of antimicrobial prescription worldwide. And within that, there is wide variation in the range and also the dosage of antimicrobials used internationally to treat UTIs. With the continued focus on antimicrobial stewardship, there has been an increase in the volume of clinical trials that investigate the various interventions for the treatment of UTIs. But there is an issue with the wide variation of outcomes being reported in many of these trials, and that then makes it difficult to make direct comparisons between the effectiveness of a particular treatment intervention. So the development of a core outcome set is a means of addressing this issue, and this is exactly where COSUTI comes in. COSUTI was led by a steering group with 11 members, all of whom are listed on screen and all of whom were based at the time in either Ireland or the UK. There were two postdoctoral researchers on the project at different times, and they were myself and Dr. Sinead Duane, who was also based in the University of Galway. The study consisted of three stages. The first stage was a systematic review, and that was conducted to identify outcomes comparing the effectiveness of interventions for treating uncomplicated UTI in adults. The outcomes identified in stage one were then brought through to the second stage, where they were presented to stakeholders for prioritization in an online Delphi survey. Then the outcomes that were prioritized in the Delphi survey were then brought forward to the third and final stage of the study, which was an online consensus meeting that was held with stakeholders to determine which outcomes will be included in the final COS. So as I said, stage one of COSUTI was a systematic review, and this was led by Dr. Sinead Duane, and a full report of the methods and results of the systematic review have been published in JAC Antimicrobial Resistance. In terms of methods, randomized trials that were conducted between 2007 and 2017 were included, and those trials compared the effectiveness of interventions for the treatment of uncomplicated UTI in adults. The Cochrane database of systematic reviews, PubMed and Embase were searched, and the outcomes identified were extracted verbatim, and similar outcomes were grouped into domains and subdomains. Then the results of the systematic review, 334 outcomes were reported across 41 papers, and it was found that the average number of outcomes reported in trials was 8. Duplicate outcomes were removed, and once that was done, there were 124 outcomes that demonstrated similar characteristics, which meant that they could be characterized within 18 domains. Then we move on to the second stage of the study. This is the stage where I joined the COSUTI team. And the stage 2 was an online 3-round Delphi survey. And the purpose of the survey was to achieve consensus on the importance of each of the outcomes identified in the systematic review. For the survey, participants were purposely sampled from stakeholder groups thought to be most impacted by interventions for the treatment of uncomplicated UTI. And those stakeholder groups were deemed to be people who have experienced or cared for someone experiencing a UTI, general practitioners, hospital-based medical practitioners, nurses, midwives, researchers, pharmacists, microbiologists, and policymakers. So ahead of the Delphi survey taking place, the outcomes that were identified in the systematic review were reviewed by the steering group. And there were a few outcomes that the group deemed necessary to further group together or combine, and that was done to minimize overlap between domains. And when the steering group were reviewing the list of outcomes, it was decided at this point that it was also appropriate just to standardise some of the time points of the outcomes. And this was done because in the systematic review, it was identified that there was a real variance in the time points within which the outcomes were measured and reported. So time points refer to, say, for example, day 3, day 7. So there were a few outcomes that the steering group decided it would be most appropriate to standardise those time points for the purpose of the Delphi, but also for the final core outcome set. So decision on what those time points should be were very much taken on an outcome by outcome basis, and it was very much done only when it was appropriate, when it was suitable for each individual outcome. So following that review by the steering group, there were 116 outcomes eligible for inclusion in the Delphi survey in round 1. So those outcomes were added to our host software, which is Calibrum, and that is a Delphi survey specific software that we used. In terms then of the format of the survey itself, we had the consent section and then the demographic section, and then following that, participants were asked to rate the level of importance of each of the 116 outcomes. They were asked to do this on a Likert scale from 1 for an outcome that is not important, through to 9 for an outcome that was considered critically important. For each outcome, participants were also given the option of clicking an unable to score box. We presented the outcome text for each of the 116 outcomes, and alongside that, we also had a plain English explanation for each. Following scoring in round 1, we added 2 questions. The first was asking participants if there were any important outcomes that they felt were missing and should be considered. And we advised that if any outcome was suggested by more than one participant, it would be brought forward to round 2 of the survey. Then we had a final question, which is a broader, more open-ended question asking, did participants have anything else to add more generally about COSUTI? So round 1 was open for 4 weeks, and within that time we had 253 people taking part. For the purpose of the Delphi survey, and presenting the findings in later stages, which I'll show you in a moment, we did combine the long list of stakeholder groups participating from those that I mentioned earlier down to 3 broader groups. So that meant that in terms of grouping those 253 participants that took part in round 1, of those 27% were healthcare practitioners, 2% were researchers, and 71%, which equates to 180 participants, were people who had experienced or cared for someone experiencing a UTI. We had people take part in round 1 from 26 countries, and most of those were from England. In terms then of our recruitment strategy for the survey, participants were recruited with emails to publicly available accounts and professional organisations, also through personal networks of the steering group. And it's important to mention that we were very fortunate to have the support of both the Care Alliance Ireland and the Chronic Urinary Tract Infection Group, both of whom shared information on the study with their members, and that vastly increased the participation from people who had either experienced or cared for someone experiencing a UTI. So we're very grateful to them for their support. We also used a Twitter campaign for recruitment, where we tweeted daily from the HRB Timaran account, and we used tweet cards to tag people and organisations who were representative of the various stakeholder groups that we wanted to engage with. Examples of 2 of those tweet cards are there on the right hand side of the screen, and we would share these daily on Twitter alongside a direct link to the survey itself. And as I said, we did include demographic questions in the survey, and that gave us a means to monitor the geographical spread of participants and also stakeholder groups, which allowed us then to focus any additional recruitment efforts where it was necessary. And it's important just to say at this point that recruitment for the Delphi survey took place only ahead of round 1. There was no additional recruitment for rounds 2 and 3. So moving on then to round 2. So there was a post hoc change made ahead of round 2 taking place. So that means that we changed the methods for round 2 that had been set out in our protocol for the study that had been published before it started. So this change came about in response to the open question that we included at the end of round 1 of the Delphi study, where the Delphi survey, where we asked participants if there was anything more generally they wanted to add. And it was really clear from the responses that we received that participants felt that 116 outcomes to score, that volume was just was far too much, and it was clear that something needed to be done to address that. So the steering group discussed the feedback that we had received, and it was decided that absolutely it was essential to minimise the burden on participants, with a view to increasing the likelihood of round 1 participants continuing to further rounds. So a post hoc change was made to reduce the volume of outcomes presented to participants in round 2. So originally, as reported in our protocol, all round 1 outcomes were to be brought forward to round 2, but instead steering group decided that an outcome would be brought forward to round 2 of the Delphi survey if over 60% of all respondents rated it as critical for inclusion. So that would be rating it 7 or over, and also to ensure that public prioritised outcomes were not overwhelmed by other groups. Any outcome with an average score of 7 or more by people who had experienced or cared for someone experiencing a UTI would also be included. So based on that criteria, 60 round 1 outcomes were to be included in round 2. Then there were 4 additional outcomes that were included based on suggestions by round 1 participants, which meant that in total there were 64 outcomes included in round 2. So in round 2 then, participants were asked to rescore each of the 60 outcomes that had been included in round 1. So to help people reflect on their earlier scores, we presented for each of the outcomes exactly what is presented on screen. This is for the clinical cure outcome, and you'll see the outcome text on the left hand side there. And just to the left of that is a blue eye. So if participants clicked on that, that is where the plain English explanation would be displayed. Then on the right hand side here we have the Likert scale from 1 to 9, and you'll see number 7 is highlighted in red. So this is to show participants what they had scored this outcome in the previous round, so they could reflect on that score. And while they're reflecting on their previous score, we also presented the 3 graphs underneath. So these illustrated the scores given by each stakeholder group for this outcome. And as I mentioned earlier, we combined, for the purpose of presenting the Delphi survey results, we combined that long list of stakeholder groups into these 3 groups presented in the graphs, and that was just to minimize the amount of graphs that people would have to consider for each of those outcomes. So round 2 was also open for 4 weeks. All round 1 participants were sent an invitation to participate in round 2. and a reminder was sent to each participant on a weekly basis. Round 2 was completed by 76% of those who had completed round 1. That equated to 192 participants, and of those, 26% were healthcare practitioners, 4% were researchers, and 70% were people who had experienced or cared for someone experiencing a UTI. Outcomes were, and then we go on to round 3, the final round of the Delphi survey. So outcomes were included in round 3 if they were rated as critical, so that's 7 or over, by at least 70% of respondents. And again, to ensure that public prioritised outcomes were not overwhelmed by other groups, any outcome with an average score or 7 or more by people who have experienced or cared for someone experiencing a UTI was also included in round 3. So in total, based on that criteria, there were 43 outcomes included in the round 3 of the Delphi survey. Similar graphic display that I showed you for round 2 was presented to each participant for the outcomes in round 3. And we did add one additional question to round 3, and that was at the end asking people to submit their email address if they were interested in taking part in the final stage of the study, which was the consensus meeting. So we just asked them to submit their emails if they were interested, and we could get in touch with them from there. So round 3 was also open for 4 weeks, and all round 2 participants were sent an invitation to participate in this round, and again reminders were sent each week to complete. Round 3 was completed by 64% of those who had completed round 2, so that equates to 123 participants. 27% of those were healthcare practitioners, 4% were researchers, and 69% were people who had experienced or cared for someone experiencing a UTI. Then we move on to the final stage of the study, where we gathered participants again from the same stakeholder groups that I mentioned previously. And the purpose of the consensus meeting was to decide upon how essential it is for each outcome discussed to be measured and reported in all clinical trials for interventions for the treatment of uncomplicated urinary tract infections in adults. The workshop itself took place online, and that was determined by the COVID-19 pandemic and the restrictions on travel that this imposed, as we had originally expected or hoped that this could take place in person. So in terms of the volume of outcomes that were discussed at the meeting, based on round 3 scoring, all 43 outcomes included in round 3 were actually eligible for discussion at the consensus meeting. So there was quite a few outcomes for discussion. All 43 outcomes from round 3 of the Delphi survey were brought forward to this meeting. We had 20 participants from 11 different countries attend the meeting. 45% of those who attended were healthcare practitioners or policymakers, 20% were researchers, and 35% were people who had experienced or cared for someone experiencing a UTI. As I said, we had participants from 11 different countries. Those countries were Cameroon, Canada, England, Indonesia, Ireland, Kenya, Nigeria, Norway, Pakistan, Scotland, and Uganda. We had 3 steering group members in attendance on the day. They participated the same as the rest of those attending, but they also acted as a source of information if needed on the processes adopted throughout the study. For the remainder of the 17 participants then, they were recruited via a multi-pronged approach. So some participants were recruited through our Delphi survey, and as I said, we had asked people to submit their email if they were interested in attending. Other participants were also then recruited via direct contact with authors on prominent research papers relevant to the topic, and also through engaging with individuals with relevant experience that had been suggested by members of our steering group. So now we are on to the results of COSUTI. So the 6 core outcomes decided upon by the consensus meeting participants are listed on the left-hand side of the screen, And then on the right-hand side, we have the corresponding definitions. And these definitions for each of the outcomes were decided upon during the meeting, and we just had some minor editing then post-meeting for wording clarity. In terms of the format of the meeting, as I said, there was quite a large number of outcomes for discussion. Those discussions took place over 4 hours. Each outcome was discussed individually, and then through voting via Zoom polls, outcomes were included in the COS if they were agreed upon by 70% or more of consensus meeting participants. So now that this COS has been developed, the results have been published, there really is just a focus on disseminating this information and making sure it gets to people who can use it in the future. And we really do encourage funders, researchers, and the scientific community as a whole to adopt its use with a view to informing future evidence synthesis and meta-analysis. So that's it really for an overview of the COSUTI project. Any of the information provided here can be found in the Antibiotics Journal, where the full text is available open access. And like I said, it's also on the Comet Initiative website, where all the publications for the study are available. So I'm going to hand you back to Simone now for any questions that anyone may have. Thanks, Simone.